So it sounds like the efficacy data was very similar between the talazoparib and the olaparib. They were very, very similar in that sort of later line population, but some differential toxicity, not wildly dramatic, but so they may not be like totally interchangeable. It sounds like, huh?
Right. I think that it's really a bit of the toxicity differentiator. You already mentioned the alopecia standpoint, where I think it was incredibly uncommon, maybe 2% or so in Olympiad versus 25% in Embraca. And alopecia is meaningful if we're trying to get away from significant toxicity for our patients. A bit more in terms of hematologic toxicity seen in Embraca with a PARP inhibitor versus olaparib on Olympiad. I think they called out in Embraca a subset of patients that had prior stable CNS metastases, and it appeared that they derived benefit. I don't think that tells us that olaparib wouldn't have benefit in that situation, but we just don't see any differential response in the setting of CNS disease.
No, I agree. I think there's been a lot made about the different PARP inhibitors and their mechanism of action and trapping PARP proteins and being more potent or less potent, and we see tables about which ones are more potent. But I think in these two, it looks like the efficacy thus far is pretty similar. So I don't know if any of that potency or mechanism of action is going to translate to clinical differences or toxicity differences.
We don't know yet.
We don't know.
That's the trapping of the PARP enzyme, so it doesn't fall off, and you really just don't complete that repair of double-strand break. So we just don't know yet. That's a potency issue, but we don't know yet clinically. But so there was more anemia.
Yes. And
neutropenia and thrombocytopenia. Is that right? With the,
absolutely. I think if you look at how much grade 3 or higher anemia there was, olaparib there was 16% in Olympiad, and there's like 40% with the Embraca study with the talazoparib. If you look at thrombocytopenia, grade 3 or higher, you're talking about 2% versus 15%. So there are differences. I mean, I think there's no doubt when you look at the studies, one thinks about, well, is one of these more potent or has more toxicity? But again, does that translate into efficacy? Will it translate into survival? I think time will tell, but at this point, I think efficacy looks similar.
And there was maybe a difference in BRCA 1 and 2 between the studies. I think, wasn't there a little suggestion with talazoparib that maybe it looked quite good in the BRCA 2, and then in the Olympiad, maybe that wasn't quite as prominent or something? I remember some
Olympiad is a 60-40 split, so 60% BRCA1, 40% BRCA2. And 50-50 on ER positive and triple negative.
And again, I think when you look at these forest plots, at this point, I can't find a subgroup of patients who met the eligibility criteria that I wouldn't use either olaparib or.
Because we're getting into subset analyses.
Which were not planned,
right. And
exploratory.
Are fully overlapping.
Absolutely.
And so, but that is something that I remember having a question on, but yeah, but it's just, these are subset analysis, and it's like everything, like the CDK4/6, every single subset benefits,